Chapter 1, we are going to talk about embryologic development of the cardiopulmonary system. Before we talk about how the cardiopulmonary system develops, we're going to talk about the development of an embryo, which will then turn into a fetus. So first we'll start with the definition of fertilization, and the textbook definition is the union of male and female gametes to form a zygote from which the embryo develops. In other words, when the sperm enters into a mature egg, you will then start the process of an embryo then turning into a fetus. So fertilization is when the egg actually is able to enter into the egg, joined together, the egg and the sperm joined together. Okay, so once that happens, then you have multiplication going on, where that union, the egg and the sperm coming together, which is called an embryo, will then start to go into three different growth stages. So you have an ovum, which is a mature egg, and it says during this stage of development, the developing organism is called an ovum. So that is between days 12 to 14. So the first stage of the first stage of a development of a fetus starts at the ovum phase. And after that 12 to 14 day period, you have the second stage, which is called the embryo stage. This is where your major organ systems will start to grow. And during this second stage, the time is measured roughly 3 centimeters from the head to the rump, or around 54 to 56 days. So it really just depends on the mother's history. If the maternal history, if the mother is able to give a maternal history to the physician, then they can utilize those days. If mom did not keep a good recollection of her menstrual cycle and how often she had a cycle and when was her last cycle and all that good stuff, then they can't really use the days. So they would have to then go via ultrasound and measure from the head to the rump. And if the baby measured roughly 3 centimeters, then they would know that they are in the embryo stage. The embryo is extremely vulnerable to the effects of drugs, infections, and radiation. So it is important that we minimize the exposure to these babies because it can lead to severe congenital malformations. Now, the third stage is called the fetus. And the fetus is where major organs begin to grow to the phase that they will be once the baby is born and delivered into the world. So the name fetus is used during the third stage from the end of the embryonic period to the end of pregnancy. The major organs have already developed during the embryo phase, and they now proceed to grow during the fetus phase. Because the organ systems are mostly developed, they are less susceptible at this phase to drugs, infections, and radiation. However, exposure may lead to an interruption to the normal functional development of the organs. So it doesn't mean that they're out of the clear and mom can just do whatever she wants to do. The baby can still be affected. Now, after the baby is delivered, we call the baby a neonate. So neonate is used from delivery through the first month of life. And an infant, the term infant is used for the period from 1 month to 1 year of life. And of course, we use the term child to identify someone who is older than 1. Okay, in order to get from fertilization to implantation, you first have to have a fertilized egg, which again is called an ovum. And then that ovum is going to start to divide and multiply. And as the cells multiply, they will form a ball of cells, and we call that the morula. As these balls of cells continue to multiply and multiply and multiply, you end up eventually with a ball of cells that are in fluid, and that's called the early blastocyst. And as that continues to multiply and divide, you end up with a blastoderm and a trophoblast. So those two different clumps of cells will then start to multiply and divide even more so, and the blastoderm will become the fetus, and the trophoblast will become the placenta. Okay, the embryo has 3 different germ layers, and each of these will form your tissues, organs, and organ systems. The endoderm and the exoderm are the 2 layers that make up the embryonic disc, and the ectoderm is the outer layer, and the endoderm is the thicker layer. You also have a 3rd layer called a mesoderm, and the mesoderm forms between the endoderm and ectoderm, very similar to the different layers of, say, your heart muscle. So these are the primary germ layers that all tissues, organs, and organ systems will differentiate. So they all come from these layers and will eventually be the structures that we will see, the different organs and organ systems that we will see when the baby is born. The organs that are most important to remember are the respiratory tract, which develops from the endoderm layer. You also have your digestive tract, bladder, and thyroid that come from your endoderm, as well as your liver and pancreas. The mesoderm is where your skin, the dermis, your muscles, your bone, connective tissue, your reproductive organs, and most importantly, the cardiovascular system comes from the mesoderm layer. And then your ectoderm helps to develop your epidermis, your hair, your nails, the lens of the eye, the central and peripheral nervous system, as well as your skin gland. Okay, now we're going to discuss the development of the lungs during fetal development. So it occurs in 5 different stages. You have the embryonic period, the pseudoglandular period, the canalicular period, and the saccular and alveolar period. The embryonic period lasts from conception to 6 weeks. Pseudoglandular is from week 7 to week 16. Canalicular period is from week 17 to 26. And then the saccular and alveolar period lasts from weeks 27 until term. With the embryonic period, this is where the upper airway starts to develop. You start to see the tubes for the oral and nasal cavity. The pharynx and the larynx start to be formed during this time frame. And then eventually the buds start to appear for the alveoli, and the bronchioles start to come more visible. And then all the way up to week 6, going into week 7, you'll start to see the development of the diaphragm. With the pseudoglandular period, which is weeks 7 to 16, there's a figure on page 8, figure 1-3, that shows the branching of that occurs, which will continue to the terminal bronchi. During this period, you also have muscle and elastic tissue and early cartilage start to form. Mucus glands start to form during this period. And as mentioned earlier, up to that 7th week, you start to see that diaphragm forming. With the canalicular period, it lasts from week 17 to 26. And this period is very important because you may be working in a hospital that is pretty progressive and will deliver babies that fall within this canalicular period. So any baby that's born prior to 26 weeks gestation, they may or may not have alveolar ducts that have been formed properly. And more importantly, they may not have the appearance of surfactant. And we're talking about just the immature surfactant. So these cells, type 1 and type 2 cells that will be producing, actually type 2 are the ones that produce the surfactant. What it is producing is not, those cells are not strong enough, so to speak, to keep the surface tension down. So any baby that is born prior to 26 weeks gestation, you can expect that you're going to have a baby with stiff lungs because they don't have that natural production of surfactant, mature surfactant. So you will, one, have to give them surfactant, artificial surfactant, and two, the baby will most typically have stiff lungs and have a restrictive component, and you will have to deal with that in your delivery of mechanical ventilation. The saccular and alveolar period, the time frame is between weeks 27 to term. And of course, with all of these periods, each neonate is going to be different on how far along they are in the 5 stages of pulmonary development. But most typically, if you get a baby that's born before 30 weeks gestation, you will be sure to be dealing with a baby that's in the saccular period, meaning that they have appearance of alveoli, they will have mature surfactant, and the alveoli will start to increase in size and number as the weeks progress. So if the baby is having some type of complication, the ideal thing to do is keep the baby in there at least to 32 weeks, but as early as 30 weeks, you may end up having a baby being born that does very well out of the womb. Once you get to the alveolar period, this is where the baby is considered to have pulmonary surfactant that is being produced by the type 2 cells. So it really, again, it depends on where the baby is in their development, whether they have gotten to the alveolar period or whether they are still in the saccular period. As your book states, true alveoli with the terminal airways are called saccules, and during the weeks between weeks 24 to 26, they have not yet been formed. True alveoli don't actually appear until around weeks 32 to 34, developing from a thinning of the terminal air saccules. So the number of alveoli continues to increase until the approximate age of 8 years old. So even once the neonate is born, they will continue to grow and develop their alveoli all the way up into 8 years. And it's during the alveolar period that the pulmonary surfactant is produced in increasing amounts by the type 2 cells. This is extremely important. That is an MBRC question. What period of lung development will a fetus develop their type 2 cells? It's going to be the alveolar period. Or they may ask you which alveolar cells produce pulmonary surfactant, and your answer will be type 2 cells. Okay, this next section talks about the forces that are on the surface of the alveoli and the role that surfactant plays in how you are able to take in a breath. And all of that should be review for you, so we will not revisit that, but you are welcome to read that section if you need to. You all should also know that surfactant is found in the alveoli. As mentioned earlier, it is produced by the type 2 alveolar cells, and it reduces the surface tension. But what is most important is that you know when surfactant is present, when and if surfactant is present, when you have a neonate that has been presented. So the first appearance of surfactant coincides with the development of your type 2 pneumocytes. Surfactant is composed of phospholipids, which the two that you must remember is PC, which is phosphatidylcholine, and then PG, which is phosphatidylglycerol. It also has, outside of those phospholipids, it has neutral lipids and also proteins. After being produced, the surfactant is then stored in the cell in the lamellar inclusion bodies. Not an important structure to know, just know that the surfactant is stored until the baby is born, because until the baby is born, the surfactant isn't really being utilized. The first surfactant to be produced lacks the PG and is termed immature surfactant. So basically, they can test the fetal lung fluid to see if it has the presence of PG. If it has PG, then it is mature surfactant. If it does not and it only has the PC, then it is immature surfactant. And this is first seen when the baby is 24 weeks gestation. During the early stage, surfactant production is easily inhibited by things like hypoxia, hypothermia, acidosis. So babies that are born prematurely, especially those born earlier than 30 weeks, are extremely prone to each of those conditions or disorders. The result is a rapid deterioration of the respiratory status following the delivery of the baby, and commonly called respiratory distress syndrome once they're born, how their lungs will present themselves. And then mature surfactant will be present in the alveoli around weeks 35 to term. And that is when, if the fluid is tested, the presence of PG will be able to be tested. Speaking of testing, how are we able to measure the fetal surfactant and determine how mature the lungs are? Well, from the first time that the immature surfactant appears, it can be measured in a sample of amniotic fluid. So the amniotic fluid can be expelled, meaning putting a needle in the mom's tummy and take the fluid and test it for the presence of the PG. So the fluid produced by the lungs contributes to the amniotic fluid because the baby is swallowing it, and it goes and saturates the lungs as well as the gastrointestinal tract. And then since it's all one whole, they're in an enclosed compartment. When the baby exhales, basically they're exhaling whatever was in their lungs. So some of the surface active phospholipids are excreted by the alveolar cells, are then carried to the amniotic fluid by the lung fluid. So when we withdraw a sample of the amniotic fluid and then compare the levels of the PC, which is also called lecithin, to the level of the sphingomyelin in the amniotic fluid, lung maturity can be predicted. So the sphingomyelin is another type of phospholipid that is produced by the fetus that remains at a fairly stable level in the amniotic fluid throughout gestation. So because that level is fairly stable, we can compare that with the level of the PC. By comparing the levels of each in the amniotic fluid, a quick determination of fetal lung maturity is possible. This comparison is called an LS ratio, lecithin to sphingomyelin ratio, LS ratio. So they're comparing the level of PC to the level of sphingomyelin. The fetal lungs are considered mature when the LS ratio reaches 2 to 1. In other words, there is twice as much lecithin as sphingomyelin in the lungs. So this 2 to 1 ratio occurs around 35 weeks of gestation, and the achievement of the 2 to 1 ratio usually coincides with the onset of mature surfactant production and indicates that there's little chance of the baby getting stiff lungs or RDS once it is born. So if the baby is having complications and they're trying to decide whether to go ahead and deliver the baby early, this is one of the things that they can do an amniocentesis for. Amniocentesis is when they stick the needle into mommy's tummy. The needle then goes into the amniotic sac. They pull back some of the fluid and then they test the fluid. They can do the LS ratio to determine if baby's lungs are mature enough to be delivered. Now, as gestation progresses, surfactant production is enhanced, and PG is produced as surfactant production reaches maturity. We already talked about that. This fact has led to the practice of testing amniotic fluid for the presence of PG, which makes sense. If PG is only present when the lungs are mature, let's just test for it instead of testing for the increased production of the other phospholipids, which was lecithin and sphingomyelin. So the combination of the LS ratio and testing for PG is actually called a lung profile. Studies have demonstrated that the lung profile is a better predictor of lung maturity than either the LS ratio or PG detection when used alone. So basically they're saying do both of them and use the ratio and the level of PG as an indicator on how well the baby's going to do. Many factors can either delay or accelerate the production of mature surfactant. Table 1-2 lists things that can go wrong, lots of things that can go wrong to slow down how well your body is able to produce surfactant in utero. Another relatively simple method of determining lung maturity is by a test known as the shake or foam test. This procedure is done by mixing the amniotic fluid with some ethanol. The mixture is then shaken for 15 seconds. A reading is made 15 minutes later, and if there is a ring of bubbles in the ethanol after 15 minutes, then that means there is enough lecithin present to create a stable foam, meaning that the surfactant is strong enough to reduce the surface tension if the baby were to be born. This technique is a fairly reliable way of determining fetal lung maturity. If the foam is not present following the 15-minute period, then the LS ratio should be performed just to confirm that the baby's lungs are not mature. There are several techniques that have been successful in predicting fetal lung maturity. The concentration of liminal bodies in the amniotic fluid has compared favorably to the lung profile in its ability to predict lung maturity. There are other tests like surfactant albumin ratio, we call that a SAR test, has been shown to be accurate in clinical studies. And then a third test called the TDX FLM assay has been used to predict RDS with much reliability as the lung profile. So checking the assays can determine if the baby is likely to develop RDS once it's born. Finally, the Florence polarization, which is called FP assay, has also been shown to accurately predict RDS. So lots of ways that we can determine or predict if the baby has mature surfactant present and is able to breathe on its own. Because we know that surfactant is very vital, and if the baby is born and they're not able to produce their own surfactant, then we have to administer artificial surfactant. Okay, fetal lung fluid, of course, is a fluid that is found in the fetus's lungs. Now, this fluid has a different composition than the amniotic fluid, which is the fluid that surrounds the fetus itself. Even though the fetal lung fluid does circulate within the amniotic fluid, the concentration or composition of the fluids are different. Fetal lung fluid has a low pH. It also has proteins and bicarbs, low levels of those, and it has a high concentration of sodium and chloride. It appears early in gestation because, as we learned, the air sacs start to develop early in gestation, and it continues to generate until shortly before delivery, at which time production ceases, because there's no need for fetal lung fluid if you now have your lungs filled with air. Of course, the function of fetal lung fluid is just to maintain patency of the airways, keep the airways patent, since you don't have a need to have oxygen present in the airways yet. The baby will be getting oxygen from mom through the placenta. So all you really need the fetal lung fluid for is just to keep the airway patent. Now, there are hazards of having fetal lung fluid present once the fetus is now a neonate. So once the baby is born, it is imperative that we get this fluid out of their lungs. If the fluid is retained, then the baby has a good chance of developing transient tachypnea of the newborn, TTN, or respiratory distress syndrome, RDS, simply because the fluid will be taking up the space of where the oxygen should be. So obviously, in order to get rid of any kind of fluid in your lungs, doesn't change because it's a neonate, positive pressure ventilation will be needed in order to pop the lungs open. The cardiovascular system develops as early as the 21st day of gestation, and it will fuse into two tubes called the truncus arteriosus, and it is the primitive ventricle of the heart, and it actually starts beating as early as 21 days gestation. Isn't that amazing? Well, those two fused tubes will then start to multiply and divide and grow. Eventually, you will be able to distinctly see the right and left ventricles and the septum. And as blood continues to flow, which blood also starts flowing as early as 3 weeks, 21 days into gestation. But it begins a one-way flow instead of the back and forth motion. The blood enters through the sinus venosus and travels through the primitive atrium, the left and right ventricles, and then out through the truncus arteriosus. And by the 5th week of gestation, the embryonic heart no longer looks like an S, but now it's starting to be more visible that there are chambers involved. So the early development of cardiac chambers, you can see that as early as 5 weeks gestation. And then you have the formation of the major vessels. You will start to see the pulmonary artery and the aorta start to develop during this division. Around the 6th week, the truncus is divided into 2 vessels by a thin tissue that spirals down the center of the truncus. These 2 vessels are the pulmonary artery and the aorta. And the tissues then continue to grow, eventually separating the right and left ventricles completely. And the newly formed aorta is now the escape route for the blood in the left ventricle, and the pulmonary artery provides the outlet for the right ventricle. During this time, the valves begin to form between the atrium and ventricles, as well as in the root of both the pulmonary artery and the aorta. And then in 2 short months, the heart has formed and begins pumping and circulating blood, and it looks like a tiny replica of an adult heart. Okay, for fetal circulation, we've already covered the differences between fetal circulation and circulation after birth. So we will just talk about the shunts that occur when the baby is in utero. So you have 4 different shunts that are occurring. The first shunt is actually from the umbilicus to the blood flows from the umbilicus to the liver first, and it leaves the liver going into the inferior vena cava through a shunt, which is the ductus venosus. It connects from the liver to the inferior vena cava. Then blood is going to mix with the superior vena cava in the right atrium, and then shunt once again through the foramen ovale. And the foramen ovale is the opening between the right and left atrium. Blood will then flow through the left side of the heart, and up to the aorta. However, blood will shunt from the pulmonary arteries into the aorta as well. So the little bit of blood that did get to go to the lungs from the right side of the heart will then return back into circulation through the shunt called the ductus arteriosus. There is a diagram if you need to look at the shunts and how blood flows. The diagram is located on page 19. Okay, baroreceptors and chemoreceptors, as you should already know, have to deal with pressure and chemical changes. So baroreceptors are the stretch receptors that respond to pressure changes, and chemoreceptors respond to chemical changes. So there's mixed in the theories of whether baroreceptors actually are active in utero, but the theory behind chemoreceptors is that they are not active, kind of like a passive activity. So once the baby is born and exposed to our atmosphere, then those chemoreceptors kind of kick into gear. As far as the baroreceptors, though, because there's not much change in pressures in utero, the theory is that they're not actually active. Nonetheless, they are important in regulating pressures for the baby, and that's usually not something that needs to take place until they take their first breath. We will talk more about chemoreceptors when we get into chapter 3. Just be sure to remember that chemoreceptors are very important for the initiation of the first breath, because that will be the first time that the baby will have a buildup of CO2 in order to take their first breath. The uterine structures, intrauterine structures that we will discuss are the placenta, the umbilical cord, the amnion or the amniotic sac is another term for it, and then the fluid that fills the sac, which is called amniotic fluid. The placenta is an organ of respiration for the fetus because it will receive the oxygen and nutrients from mom, so that the baby can utilize it, and then it will get rid of all of the waste from metabolism, which is CO2, so that the baby can not be toxic. So that connection between mom and baby is extremely important. So the placenta is that lifeline. The umbilical cord, well, the placenta is the life object, and the line between that object and the fetus is the umbilical cord. So the lifeline between mother and fetus is the umbilical cord because it connects the fetus to the mother. The amnion or amniotic sac is around the baby. It's a membrane that keeps the amniotic fluid surrounding the baby for protection. As the next bullet state, amniotic fluid fills the amniotic sac, and it aids in water needs of the infant. So the fetus will swallow the fluid and excrete it. And it is also important for thermoregulation in utero and facilitates fetal movement. So these structures are very important to understand their role, because these are common areas for complication. The placenta has to implant in the endometrium, the wall of the uterus, and anything can go wrong with that implantation. It can implant and then get dislodged. That can cause complications. The umbilical cord, there could be a prolapse, and therefore the baby will not get any nutrients from mom through the cord coming from the placenta. The cord could get wrapped around the baby's neck. Lots of umbilical cord issues. During contraction, the umbilical cord can get compressed. That's a major, actually pretty common type of complication. The sac, the membrane could rupture prematurely. That would be bad. And with the fluid, you could have decreased levels of the fluid, which would cause there to be less movement of the fetus. And that is typically what happens as you get closer to your delivery date. The baby doesn't have as much room to move anymore because the baby is outgrowing that amniotic sac. But when it's earlier in gestation, the baby should have enough fluid available so that it can move around. If there is not, if you have low levels of fluid, then that could cause complications because the baby won't be able to move as freely. And the term for that is oligohydramnios. Oligohydramnios is scant or decreased amount of amniotic fluid, but you can also have an increased amount, polyhydramnios. The amount of amniotic fluid present at birth is dictated by how much the fetus swallows and urinates. An abnormally large amount of fluid, usually over 2,000 cc's, indicates hydramnios or polyhydramnios. And its presence indicates that there's a problem with the fetus's swallowing mechanism. Usually that could indicate that there's some type of central nervous system malformation, maybe hydrocephalus, microencephaly, anencephaly, spinal bifida. There could be some type of gastrointestinal problem, oral gastric malformation like esophageal atresia, pyloric stenosis, cleft palate, Down syndrome, CHF even, and then moms who develop gestational diabetes, their infants are usually much bigger than normal. So you could have problems with increased amounts of fluid where the amniotic fluid is concerned. And then prematurity. So the major complications for the fetus with hydramnios is the risk of PROM, which is premature rupture of the amniotic membranes, because baby is growing and all the fluid is increased and it's just pushing on that membrane. And it's just a thin, it's not, it's thick enough to protect the baby, but as you keep pushing on it, it's not very thick, obviously, which is why it can rupture on its own. The other issue with this is that it could cause a prolapse of the umbilical cord, and you can also have premature delivery. Okay, that ends our talk on Chapter 1, the development of the fetus.